Okay, so today I'm going to talk a bit about tricuspid and pulmonic valves. I'll start by introducing myself. My name's Alex Nesbitt. I'm the Echo Fellow at the Mater Hospital in Brisbane in Queensland. And I'll talk about these two often forgotten about valves and assessment of them. So what we'll cover is the anatomy of each valve, some of the pathology affecting each valve, and also the echocardiographic assessment of each. Now, I said that they were often forgotten, and the right side of the heart has, I guess, historically been forgotten about, is increasingly being seen as and recognised as being important in recent years. But it's important because a not insignificant amount of our patients, or number of our patients and people walking around in the community have right-sided heart disease, and in particular moderate to severe TR. And the all-cause mortality increases with the increasing severity of that TR as well. And that's even when you adjust for AF, pulmonary hypertension, left ventricular dysfunction, and MR, or other conditions that are expected to cause tricuspid regurgitation. And you add that into the fact that we have an aging population, and you'll see that this is going to become even more important over the next few decades. So starting off with the tricuspid valve, we probably already know that it's got three leaflets: the anterior, septal, and posterior leaflets. Anterior is the longest, septal the shortest, and posterior somewhere in between the two. Now, the venous side of the circulation has quite a significant amount of variation between individuals, as you probably already know. And so 40% of us actually have a quadricuspid tricuspid valve, at least in the series that I was referring to when I looked this up. And about 5%, or 1 in 20 of us, seem to have a bicuspid tricuspid valve. The annulus is less stiff than the mitral valve annulus. It's kind of a D-shaped ellipsoid with a saddle-shaped profile, a little bit like the Pringle profile that the mitral valve has, but less stiff. And there's close associations with the AV node and the right coronary artery, both things that are important if you're going to put sutures around the annulus. And I guess there's a similar-ish subvalvular apparatus to the mitral valve. Having said that, there are usually three papillary muscles in 80% of us, and 20% of us don't have the medial papillary muscle, and the rest of us have anterior, posterior, and medial. There are a number of different types of cords, or chordae, and there's about 25 in total. And they're less distensible than the mitral valve chordae, which means that when the right ventricle distends and the tricuspid annulus expands, you're more likely to get a coaptation defect and tricuspid regurgitation. So this is a modified surgeon's view of the heart. And as you can see on the left-hand side in diastole and the right-hand side in systole, you can see that the septal leaflet is here, the anterior leaflet is here, and the posterior leaflet is here. And when the valve, when the ventricle dilates, the annulus dilates in this aspect. And the reason for that is because the portion of the annulus that is attached to the septal leaflet is much more firmly anchored to the cardiac skeleton, as opposed to the much less stiff and less tightly anchored remainder of the annulus around here. This is another way of looking at the tricuspid valve, again from a surgeon's orientation. So you can imagine the SVC and the IVC have bypass cannulas in them, and you've opened up the right atrium, or someone's done that. and you can see the leaflets as they are labelled. You can also see the atrioventricular node, the tendon of Todaro, the coronary sinus, and the septal leaflet. And these make up the triangle of Koch, which is important for cardiac surgeons to know about, and also important and mostly important in particular with regards to the conduction system. So now we'll move on to looking at some pictures and looking at the tricuspid valve in our standard views of in transthoracic echo. So this is the RV inflow view, where we'll be tilting from our parasternal long axis view. The ventricle is here, right ventricle is here, and the right atrium is here. And so what we've got up superiorly, or here, is the anterior leaflet. And then we don't actually know exactly which one this is, as in terms of whether that's going to be the septal or the posterior, because you don't know exactly where you're cutting through the valve itself. So this, in this view, is always anterior leaflet, but this leaflet could be the posterior or septal. You'll recognize this view as a slightly modified or slightly tilted version of the parasternal short axis. The aortic valve's here, the left atrium's here with the septum there, the right atrium here, and the right ventricle. This is always going to be the posterior leaflet, and this is the septal or the anterior leaflet. You'll recognize this again as a slightly modified right ventricular view in the apical forechamber. And the leaflet most proximal or closest to the septum is the septal leaflet, always. And then this leaflet is either anterior or posterior. So in each of those three views, you know which one of the leaflets is going to be, and the other leaflet that you can see could be one of the other two. And just for completeness, we can look at the subcostal forechamber, and we can look at the tricuspid valve in that. So that's here, of course, between the atrium and the ventricle. So we'll talk a bit about tricuspid regurgitation first, because it's the most common out of the four hemodynamic states that we'll talk about today. But what's most interesting, I think, is that actually primary tricuspid regurgitation, or being caused by the leaflet or leaflet disease, is actually quite rare compared to secondary, which is 90% of tricuspid regurgitation that we see. And the most common cause is actually iatrogenic. So putting pacing leads through the right side of the heart, through the tricuspid valve, leads to tricuspid regurgitation, obviously. And often the leaflets then actually tightly adhere and wrap around those pacing leads, but still result in quite a bit of regurgitation. And so that's about 40 to 60% of that 10% of tricuspid regurgitation, which is primary. And there are other primary causes because of myxomatous degeneration, rheumatic heart disease, carcinoid endocarditis, and congenital causes. Chest trauma is always mentioned. I've never seen TR from chest trauma as yet, but I'm sure I will do. And then moving on to the secondary causes, the most commonly being left-sided failure, left-sided valve disease, so severe mitral regurgitation, pulmonary hypertension, and atrial fibrillation as secondary causes of tricuspid regurgitation. And it's important to think about these different etiologies in assessing for TR and for working out what's happening to the patient in front of you, the patient that you're scanning. So we'll move on to the echo assessment of the tricuspid valve, and in particular of tricuspid regurgitation. So first of all, important always to look at the 2D appearance. What do the leaflets look like? Are they thin? Are they thickened? Is there an obvious coaptation defect between the two leaflets that you can see? Looking at the subvalvular apparatus, is there a flail? Is there a cord that's flailing? Is there thickening or hypertrophy of the papillary muscles? And looking at the adjacent chambers, is there atrial dilatation? Is there ventricular dilatation? Or are they hypertrophic? So that's the 2D assessment. We then need to think about looking at the regurgitant jet itself in colour flow Doppler. And there are different ways to do that: qualitative, semi-quantitative, and quantitative. And we'll cover a very limited amount of that today. And then you want to think about the effect on the hemodynamics for your patient, looking with spectral Doppler. So this is straight from the American Society of Echo guidelines, looking at assessment of tricuspid regurgitation. And for those of you who have seen this before or have seen something similar to this before, you'll see that I've specifically left out these values. That's because we rarely in critical care echocardiography measure them, but also because just popping them in this presentation, I don't think you're going to learn them and remember them straight up. I think it's important to focus on the things that are most useful for us at the bedside. And really what we want to do is decide whether your patient is in the mild category or in the severe category. And if it's not one or the other, they're probably moderate and less likely to be causing a hemodynamic problem. So the things I think are most important are the continuous wave Doppler jet, which will be faint or incomplete, which we'll show shortly, in mild TR, or be more dense in moderate, or dense and triangular in severe TR. Looking at the jet itself, so a big jet that's running down through the middle of the valve, or that's running all the way around the atrium, is more likely to be severe. And then looking at the vena contracta width and a Pisa radius, even though I've just said that I'm not going to give you the quantitative values, I have given you the Pisa radius because that's something that can be done if you zoom in and you know what you're doing. But then you should also look for systolic flow reversal in the hepatic vein Dopplers, and that's the beginning really of advanced echo, and it takes us a bit further along than our basic echo that we learn for example, for the College of Intensive Care Medicine's echo curriculum. This is another visualization of that with a good flow chart. You'll have all seen the ASE flow charts for each condition. I think they're quite useful, but I think it's important to know where this lives so that you can go and have a look at it, but also know what it distills down to. In particular, I find it useful to distill down the diastolic dysfunction guideline into something like a flow chart and with a few little bullet points in my mind. And likewise, I think you can do the same with the TR one. So really what we want to look at is the leaflets, the coaptation, looking at the chambers, the atrium and the ventricle to see if they've dilated. Having a look at the jet area, the vena contracta. If there's a flow convergence zone, which I'll show you shortly, it's much more likely to be at least moderate. And then thinking about some caveats to the colour flow Doppler, because this is all colour flow. The caveats are loading conditions, and including having a reduced cardiac output or reduced RV function, because that's likely to make your jet look less severe than it is. An eccentric jet will lose kinetic energy as it runs around the wall of the atrium and therefore look less severe than it is. And if it's torrential, there might be such a minimal gradient between the ventricle and the atrium that actually it doesn't look like a significant jet, but there's free-flowing blood between the ventricle and the atrium in systole. Finally, almost finally, looking at the density of the regurgitant jet on continuous wave Doppler, and then looking at systolic flow reversal in the hepatic veins, and the caveat to that being AF. Similarly, your CVP, or looking at your CVP when the patient's in AF isn't going to be particularly helpful. Likewise with the hepatic vein Doppler. And then you want to put it all together. Is this primary? Is this secondary? The money's on it being secondary usually. And is there an underlying cause that's apparent? Is there a wire going through the valve, or has the patient come in with the label of having carcinoid syndrome, for example? So we'll look at a few pictures now. This is just showing you the characteristics of the regurgitant jet initially. So in mild TR, you have this jet that's doesn't have a very big surface area. It's central. It's not going very far through the atrium. It's bigger in severe TR and is eccentric. And if it's central in severe TR, it's going to be going further back. And there's a flow conversion zone here, which I think on the next slide we'll show a bit more about. I'll talk a bit more about. We then skipped on to looking at the continuous wave Doppler images that correspond to these severities of TR. And you can see that this is quite faint. This is all quite faint compared to forward flow. And so that's suggestive of being mild. Likewise, this envelope is incomplete. So you can see that there's all this dark area that we're not imaging essentially the flow of the regurgitant jet, which suggests again that it's mild. Whereas when you have a jet that's dense, again in comparison to the forward flow, it's more likely to or rather than more likely, it does signify a greater regurgitant blood flow. And just like in this severe example here, you might also get a triangular shape or an early cutoff in that in the Doppler envelope. And what that's showing is very quick equalization of pressure between the two chambers and a lot of blood flow. Again, the density here is pretty similar to the density of forward flow.
Attention all staff, a code red alarm has now been investigated. Stand down. Attention all staff, the code red has been investigated. All clear, stand down. Thank you.
So this slide is showing the different components of the regurgitant jet. So this is an apical 4 chamber, and what we have here is the vena contracta, which has been measured or marked helpfully here. That's the narrowest part of the orifice when the valve is supposed to be closed. Sorry, not the narrowest part of the orifice, the narrowest part of the regurgitant jet. This here is flow convergence zone, where all of the flow of blood that's heading towards the orifice is accelerating to a constant velocity. And you can make inferences about the velocity at which that is. And in a talk about PISA, we'll learn about how the inference that you can make and the quantification that you can make of the regurgitation based on that. But the presence of that dome that we saw is suggested that there is at least moderate regurgitation. So you have the proximal convergence zone, you have the vena contracta, and then after the vena contracta, so from here you have the regurgitant jet itself. We can then move on and talk about hepatic vein Doppler. And so what we do here is we take a pulse wave sample volume and place it just inside the hepatic veins in the subcostal view. What we're then looking at here is on the x-axis time and on the y-axis blood flow. So as you know, systole being during this part of the cardiac cycle, we should expect blood to be flowing towards the right atrium, which it is here. In severe tricuspid regurgitation, you actually have reversal, which makes sense because as the ventricle is contracting and blood is going in the wrong direction into the atrium, you'll see that then transmitted up the column of blood or down the column of blood to the hepatic veins, and you get this fairly significant tricuspid regurgitation or systolic reversal of hepatic venous flow. So what we're looking at here is an example of tricuspid regurgitation. And if you were sitting with me in the room, we'd talk about what view this is. We'd talk about how severe you might think that this regurgitant jet is. And that's obviously just from the colour. So we'll move on to think about the continuous wave Doppler in order to have a look at the density compared to forward flow. And you might say here that, well, there's a fairly complete envelope. And it's quite dense, but it's not as dense as forward flow. And so what I think I would call this is mild to moderate regurgitation. This is actually from the same patient, and in apical 4 chamber, you'll see that actually it looks more significant, I think, in this view, and that's common with different views. You might see a slightly different color jet, and that's why using the color jet itself is unreliable, or using the color jet itself in one view is unreliable in terms of grading the lesion. And I think there is a flow convergence zone starting to look like it's there with the eye of faith. Again, I still think that this is mild to moderate, probably more so closer to moderate. And I don't know of anybody who actively measures the regurgitant jet, which is obviously in the guidelines, and measures the area of the regurgitant jet. I think that's too unreliable in order to grade the degree of regurgitation. Again, when we look at the continuous wave Doppler picture, again we see a complete envelope and a relatively dense spectral Doppler trace as compared to forward flow. And so again, I think closer to moderate than mild. Without having, this is obviously from a different patient, but without having the regurgitant jet in a color or a 2D loop, it's quite difficult for us to make an assessment of how severe it is. However, what I think is that this is actually incomplete, and we're likely seeing something that should be more complete. It's not very dense here compared to forward flow, and therefore I think this is mild MR. This is a different patient and an example of a lovely bright echogenic pacing wire coming through the tricuspid valve and causing regurgitation. You can see a couple of orientations of regurgitant jet there too. This is a different case. There are a few abnormalities here. You'll probably be able to appreciate that. Again, apical 4 chamber. You might think, well, the right ventricle looks dilated, the right atrium looks dilated, and I think that the valve leaflet, one of the leaflets is here, one of the leaflets is, well, it should be out down here, shouldn't it? But I think actually you'll find that it's quite a bit higher up. It's up here, because this is an example of Ebstein's anomaly, and there's a large regurgitant jet just up there where I've made that marking, and in 2D you can measure the apical displacement of the septal leaflet of the valve by a significant amount. On continuous wave Doppler, you can see the early cutoff of rapid pressure equalization in severe TR or torrential TR, which you'd expect with Ebstein's anomaly. And you can see, in fact, that there are multiple jets, which is obviously then difficult to quantify if you are using quantitative methods. But again, that's beyond the scope of this talk. So this is Ebstein's anomaly. You have apical displacement of the one or more leaflets, and that causes atrialization of the ventricle, which means that part of the ventricle functionally becomes involved as the atrium. There's usually in here somewhere an ASD, and there's a small right ventricle as well, associated with a number of congenital heart diseases, such as patent ductus, and also associated with maternal lithium use, as well as other drugs. But congenital heart disease is for another day. So again, distilled down, what are we going to look at for TR? We're looking at the leaflets, the coaptation, and the size of the chambers in 2D. We're looking at the jet itself to look for a large jet area visually, the vena contracta, the presence of a flow conversion zone suggesting at least moderate TR, and really the density of the regurgitant jet on continuous wave Doppler. If you think it looks like it's at moderate to severe, then go looking for the systolic flow reversal in the hepatic veins. If it's just mild, you don't really need to add that on, but I think it's always useful if you can do it with ease and you're experienced. And then put it all together, primary or secondary TR, or is there an underlying cause that you can see? So we'll move on to tricuspid stenosis. This is usually caused by rheumatic heart disease, and there will almost always be mitral disease as well at this point. Carcinoid disease, again, congenital heart disease, you probably already know about that. And then endocarditis and the presence of right atrial masses, which cause stenosis by obstruction. Compared to tricuspid regurgitation, the findings that are suggestive of significant tricuspid stenosis are listed there on the right-hand side. And that's because there's actually quite limited evidence and limited data in terms of tricuspid stenosis and what that means. So that's why there are fewer things to look at, fewer things to measure. This is an example of measuring the gradient across the valve by tracing the inflow velocity across the tricuspid valve. On this next trace, you could do a pressure half time or a deceleration time and convert that to a pressure half time. And you can use those to ascertain what the effective orifice area is. But I won't go into too much more depth with that because it is really very rare. Now we'll talk about the pulmonic valve. So the pulmonic valve, as you probably know, is the most anterior valve. It rests in its infundibulum, whereas of course if you think back to your embryology days of learning about embryology, the aortic valve's infundibulum is absorbed. There's the left, the right, and anterior leaflets, and these are thinner than those of the aortic valve. Why is that? Well, there's less, there's the same flow, but there's a lower pressure burden, and that's resulting in less, I guess, hyperplasia of those valve leaflets. The annulus, it's not really an annulus, it's more of a, I guess functionally it's an annulus, but it's the muscular body of the right ventricular outflow tract, and that's less rigid and less uniform than we assume the left ventricular outflow tract to be. And that's important when you're thinking about actually measuring the flow across the pulmonary valve when calculating shunts. So how can we look at the pulmonary valve, the pulmonic valve? This is the right ventricular outflow tract view, and that's an adaptation of the parasternal long axis view, as you know, where we tilt the probe inferior and therefore the beam anterosuperior in order to visualize the pulmonary valve as a little seagull just up here. And so what we're seeing there is we're seeing outflow tract, we're seeing main pulmonary artery, and then if you get a good picture you can see the left and the right pulmonary arteries branching off as well. This is just another view. This is now in short axis. So again, parasternal short axis, aortic valve, the tricuspid valve's over here, and we can see the whole of the RVOT finishing with the valve at the head of my arrow there. Again, the main pulmonary artery and branches. And you can pick which one that you want to use in order to do your Doppler measurements as to the best angle of insonation. I've added this just for interest, really. I was doing a subcostal short axis. You can see the livers here. And I found that I had a really nice view looking straight down the RV outflow tract towards the valve again at the head of my arrow there. So how do you assess the pulmonary valve? Well, look at the leaflets. They're going to be harder to see than the aortic valve leaflets, especially in a young person. And the valve is harder to see than the aortic valve as well. You want to look at the RV and the RA size, because the most common causes of pulmonary regurgitation is going to be pulmonary artery hypertension, and that's going to cause RV and RA dilatation. You want to look at the pulmonary artery diameter as well, again for the same reason. We'll then look at the colour flow Doppler. So you want to look for turbulent flow suggesting stenosis, looking at the length and the width of any regurgitant jet and the vena contracta, which you can measure but is very infrequently done, and looking for a flow convergence zone. We'll then look at spectral Doppler, looking at the density of the jet, pulse wave and continuous wave Doppler measurements in the RV outflow tract. And it's important to note that there's quite a lot of respiratory variation in the magnitude of the jet that you'll see, and in the magnitude of the Doppler measurements, spectral Doppler measurements as well, and that's because of the effect of the changes in flows and pressures with tidal ventilation. So talking about pulmonary regurgitation, first of all, most of us have an element of this, 20 to 70 or 80%, depending on the study or the series that you look at, and mostly it's tolerated pretty well. Mild to moderate regurgitation is tolerated well, but when it becomes severe, you'll develop RV overload and dilatation, and that will lead to TR. And there are many causes for this, most importantly and most commonly pulmonary hypertension of all groups, the congenital heart disease that's been corrected. And when I say that's been corrected, often that's with, for example, a pulmonary valvotomy causing torrential regurgitation. There might be endocarditis, quite rare on the pulmonary valve, but it happens. And again, trauma, carcinoid, rheumatic heart disease, and myxomatous or age-related degeneration. So I've already boxed off the most important, or the most useful rather, measurement or assessment to make in terms of what I do every day when I'm doing a scan, and that's looking at the jet density and the contour of that density in continuous wave Doppler, which I'll show you shortly. So if there's not very much there, it's quite either incomplete or soft, and it's going to be mild. If it's more dense, then you're likely to see you're likely to think it's more likely to be moderate or severe in severity. So this is a nice example of a nice mild pulmonary regurgitation. You see I think it's quite a pretty flame of pulmonary regurgitation in red and gold, just here. And obviously that's in contrast to the forward flow in blue. And when you put continuous wave Doppler across that, what you find is you have this, this is more complete, but this kind of incomplete spectral envelope, which isn't very dense when you compare it to forward flow. And again, so that's more likely to be mild. This is a really good example of looking at the 2D appearance of the valve and the leaflets, because if you look closely, you probably see that this leaflet just appears to be there and isn't doing very much. And indeed, when you look at colour flow Doppler, you see that the leaflet does move a little bit, but there's this torrential regurgitation jet, which you might actually miss if you weren't looking for it. And the fact that the patient's had a pulmonary valvotomy is in the history, you hope, but the history is not always there. And so it's important when something looks turbulent like this and abnormal to think, is this actually torrential regurgitation? And this is a continuous wave Doppler through that regurgitant jet. So this is obviously very dense, and the same on this one. And it's as dense as forward flow. There's also very rapid pressure equalization, and so they've measured a pulmonary a pressure half time here, which is about 42 milliseconds, and that's less than 100, which will be the cutoff for likely to have severe pulmonary regurgitation. But you didn't really need that to do that measurement, did you? When you looked at the spectral envelope, and also when you looked at the appearance of the colour jet. So now we'll move on and finish off with pulmonary stenosis. This is almost overwhelmingly present only in congenital heart disease, whether it's pulmonary atresia, unicuspid valves, bicuspid valves, a dysplastic valve, when it's associated with complex lesions like tetralogy of Fallot or other chromosomal abnormalities and congenital rubella. And it's important to remember that it can be the valve that's stenotic or the infundibulum itself. It's a very simple assessment for the pulmonary for pulmonary stenosis, but you'll be looking for cusp thickening or limited excursion. You'll be looking for post-stenotic dilatation of the main pulmonary artery. That also happens with aortic stenosis, if you remember back to your aortic stenosis reading and learning. And you'll also be looking for secondary features of RV pressure overload. You can look at the continuous wave Doppler across the valve or down the main pulmonary artery, and you'll be looking for a peak velocity, which you can use the simplified Bernoulli equation to calculate a gradient. And it's pretty simple for pulmonary stenosis. Less than 3 is mild, greater than 4 is severe in meters per second. This just shows the RVOT pulse wave Doppler, which is demonstrating the RVOT VTI, and you can use that then to calculate pulmonary flow from when you do measurements of the RVOT, which is part of our right heart assessment talk, rather than being covered today. The reason I've got it here is because it's one of the 2 measurements really that we make in this situation. The other one, as I mentioned just before, is the peak velocity. So you want to have an angle of inclination that's running directly down the main pulmonary artery or down the RV outflow tract straight through the pulmonary valve, and you want to see a nice dense forward flow, and look for the Vmax, or maximum velocity, which is here. It's obviously a lot less than 3, so there's no pulmonary stenosis here. So as I mentioned, the echo assessment really is looking at the leaflets, looking at the RV and the RA size, the pulmonary artery, looking at any regurgitation or jet or turbulent flow and colour flow, and then looking at the density of the jet in spectral Doppler, making those measurements that I just mentioned, and then thinking about whether these changes are constant with respiration. And the reason that's important, as I said, is because those measurements and the flows and pressures are quite different in inspiration and expiration, and it's important to therefore average a number of different measurements in order to get something that's accurate and representative of your patient's hemodynamic status. Having said that, many of us don't do 8 to 10 measurements and average them out. So just some takeaway points. bit of a meandering talk around the two right-sided valves. Obviously a lot of information there. I think some food for thought is, or things that are interesting, are that those right-sided valves are often harder to visualise. And they're even harder to visualise with the toe because they're in the far field, aren't they? There's not much data on what's normal or on pathology, and so you can't really use a single parameter for grading pathology, but it's important to know that grading the pathology is actually important, and it's going to be important for mortality. Right-sided heart disease is associated with increased mortality, but also other complications, as we know, and so it's going to be pretty healthy fodder for the interventional cardiologist over the next few years as they start to intervene upon valves, and then start to see what happens to those valves after they intervene. So I think the next 10-20 years will be very interesting for the right side of the heart. Some extra reading, so a recent New England Journal article, New England Journal review on the tricuspid valve and regurgitation, and then the ASE and the BSE guidelines offer good overviews as well. So I'll leave you with that, and happy scanning.